Right. So good evening, everybody, and thank you for this second invitation to this extremely successful webinar, and my congratulations to the organizing committee. If we talk about shoulder instability and anterior shoulder instability, of course, the essential anatomy is the capsulo-labral complex. As you know, specifically the inferior glenohumeral ligament is composed of two bands, an anterior and a posterior band, which makes it a sort of a hammock-like structure that specifically tightens in abduction and external rotation. When a recurrent shoulder dislocation has taken place, basically it's a detachment of that specific hammock on the glenoid side that is the most common problem when we talk about anterior instability. Historically, the best surgical repair for this lesion was an open Bankart repair with important and capsular shift. And this was a very efficient and successful surgery for many athletes that have been treated by this many times. Since 2 decades or so, this exact same technique has now been reproduced in an arthroscopic technique, but the same principles are important. Mainly, it's a repair of the labrum plus a shift of the anteroinferior capsule. This is usually done using conventional techniques with 3 to 4 portals, 2 to 3 cannulas, depending on your technique, and the use of suture anchors. And this is done using metallic, bioabsorbable, or something in between, meaning the biostable anchors such as PEEK. And in this way, it's possible, just like you see on this arthroscopic video, to anatomically repair the lesion in this first-time dislocator, a young goalkeeper of 18 years old. The results historically have been very successful, especially in the first decade of this century. Many authors have reported a low rate of recurrence, as you can see here. On the other hand, as we followed the results much longer and longer-term follow-up became clear that the success rate was not that good as we estimated they were, with some people reporting up to 35% of recurrence rates with longer follow-up. In a known data set in a population in patients with recurrent anterior instability without bone loss, we found in our own series recurrence rates up to 9%, which is a very acceptable rate. But when we stratified them to contact sports, we found that up to 20% had a recurrence of their dislocation. This is an example of I would say, a contact sport. This is a professional judoka who is defending his European Championship title. He's in blue, and as you can see here, he has a recurrent anterior dislocation of the left shoulder. He had an arthroscopic repair done many years ago, and now he has this recurrence. This is his post-trauma arthro-CT, and as you can see, the labrum is still intact, but like in many cases, it's just the whole anterior capsule that has been torn off. And this is important to understand that arthroscopic soft tissue repair is not only the labrum, but it's also the capsule that needs to be repaired well. For this type of injuries and this type of athletes, high contact athletes, we think that there is only one solution, which is the Latarjet procedure, is the bony procedure. And I think nowadays in this type of patients, we would do the exact same operation for the first time as well. So no arthroscopic soft tissue repair in this type of contact athletes anymore. Other people have looked at predisposing factors for failures after arthroscopic Bankart repairs. And as you know, there are specific pathoanatomic considerations, but also patient-related situations. And for me, bony defects and the extent of the capsular lesions are very important. Implant failures, but also surgical error or poor healing are important factors to consider. I think the technique is important, and like I said, it's not just only a labrum repair, but it's also the capsular shift. It's tightening of the whole antero-inferior capsulolabral complex, as you can see here, so that it's really stabilizing the whole antero-inferior part of the shoulder. And this is something that is very important when you perform an arthroscopic Bankart repair. In some cases, there is no Bankart lesion, like in this one, where there's just laxity with anterior instability. And it's exactly the same principle where you will grab part of the anterior capsule, the soft tissue, and put some loose sutures, single sutures, to repair the capsulorabral complex. Again, just like you see here, many sutures on the anteroinferior parts, and even on the posterior on the posterior-inferior part as well. We put some extra stitches, and this would be the end result in a patient with recurrent instability without a Bankart lesion. And as you can see, we do an important shift of the capsule of the anterior-inferior part, but also of the posterior-inferior part, which stabilizes that shoulder well in a patient without a Bankart lesion. This type of repairs can be done with simple sutures alone, but also using the newer type of suture anchors. And this newer type of suture anchors, we do use them as well here as in the standard Bankart repairs. As you can see, they're very fine and precise. They are much less invasive to the bone and are very efficient. The question is, why would we switch from the traditional anchors? Here's a patient that had an arthroscopic Bankart repair done with metallic anchors, as you can see, 6 months before this X-ray, when he started to have pain and grinding symptoms, locking symptoms. As you can see, there's an ongoing arthritis, and on arthro-CT, you can see that one of those metallic anchors is just 1 millimeter broad on the articular surface. When we scoped this patient immediately, this is already the damage that has been done by one of those anchors that is just a couple of millimeters above the articular surface. The surgery was not done in our institution. We do not use these type of metallic anchors anymore. As you can see, they can be very harmful to the cartilage. So I think this is one of the reasons why we like to use all suture anchors. There is no metal in the anchor. It's much less aggressive to the joints. It relies on cortical bone fixation, where it deploys on the glenoid rim. The pull-out strength is comparable to classic suture anchors, and you can also use them in a percutaneous technique. The results have been very successful so far, with a very comparable clinical outcome to classic suture anchors, with recurrence rates we have reported to 7%. And the small bone cysts that you see once in a while on postoperative MRIs, as you can see one here, do not have any clinical implication in our study population. This is an example of one of those patients where you can see there's a very small drill guide used, 1.4 millimeter drill guide and drill pin used. Makes a very tiny hole on the rim of the anteroinferior part of the cartilage. The anchor is introduced, and it's just very specific and very fine technique, as you can see here. It's actually also very stable. When we put on this, it's quite stable. As you can see here, it's a great pull-out. It's as strong as a classical suture anchor. The other advantage of this is that it can be used percutaneous, as you can see here, for a posterior labrum repair with a classic cannula on the posterior inferior part. And then we use a needle to determine the right position of the entrance, make a small stab incision, and then bring in that all suture anchor through that small stab incision. And as you can see, this now can be used as almost as a percutaneous technique. where multiple anchors can be introduced through a very small incision. So in conclusion, for me, suture anchor repair for recurrent anterior instability, for no contact sports, no bony lesions, and a good capsule, this is the best indication for soft tissue arthroscopic Bankart repair. And I think Bankart repair is a labrum repair with capsular shifts. When there are important bony lesions, patients that do contact sports and in revisions, a bony procedure is much more reliable. When we speak about the different types of anchors, classic suture anchors can still be used, but I do not recommend to use metallic anchors anymore in the glenohumeral joints. When you insert suture anchors, make sure that you use a meticulous insertion technique, that they're not crowds. Even the peak anchors, this can damage the cartilage quite fast. And if there are any locking or grinding symptoms in the patient postoperatively, act fast and do a rescope. I prefer today to do all my Bankart repairs arthroscopic using an all suture anchor. I think it avoids an anchor-related complication. It's much more minimal invasive, and it's an easy technique. Thank you very much for your attention.